Good morning to everyone. I am Dr. Rangan, Dr. Sabri, and Dr. Daiba. And thankful to Dr. Samraj Jankar and the team for organizing this wonderful program. Dr. Balu is a good friend of mine from PSG, Coimbatore. And though we are all practicing this surgery of fistula for decades, definitely there is something to add up. That's what we are all here, come as more of a student, I will say. And anatomy is the key of everything to start with fundamentally to understand the problem. Here we are. We know something, we don't know many things, even in that small area of 3 centimeters. So here Dr. Balu is here to enlighten us on that. Over to you, Dr. Balu.
Thank you, sir. Good morning. I thank the symbiosis team, Dr. Samraj Jankar, for inviting me and giving me this opportunity. Mine is probably the easiest talk of the day. He's got many lectures on the anatomy of the fistula, including one session even for the anal gland. So my job is to give a very broad overview on probably the easiest. So I'm going to touch upon the broad overview and then leave it to the rest to get into the details. As surgeons, we know that without anatomy, it's like driving without a Google map these days in an unknown territory. So without anatomy, we are going to reach nowhere. And to quote Alan Parks, successful management of anorectal abscesses and rather fistula require an in-depth knowledge of the pelvic floor anatomy and potential anorectal spaces through which the sepsis can spread. So it's impossible to perform operations without accurate knowledge, and in this case, this is particularly true in the case of the fistula and ano, where intemperate surgery can lead to disastrous results. If we don't know the anatomy, we know where we are going to end up in, a definite recurrence and possibly a patient who's incontinent, who is worse than what he came with. So to just follow up with Park's words, we will move on to the anatomy. So today our anorectal surgery stands on the shoulders of these giants, Milligan, Golliger, Alan Park, Shafiq, and recently Arun Rajunasakul, who has given us a little different perspective even in the anatomy with his cadaveric dissections. So coming to the anal canal, which we are all familiar about, we have a surgical anal canal from the anal verge going up to the anorectal ring, about 4 centimeter in the female and 4.4 centimeter in the male, and the anatomical anal canal, which is from the anal verge till the dentate line. So the thing to understand is that the length is not same anteriorly and posteriorly even in the male. So you won't cut the same level of sphincter in the male anteriorly and posteriorly. That's why you try to be more conservative anteriorly. You try to cut little less anteriorly than which you will do posteriorly. The length is different in a female, so you do not want to cut anything anteriorly in a female because the length is much lesser there. And in a female, you will be less aggressive in cutting a sphincter even when it is posterior. So normally we say you may go from 30 to 50% in a male, but in a female you'll go around 30% and probably less or nothing anteriorly. And when you come to the other salient points here, you know that there is this muscles which are very important for us and the fascia which are important for us. We know the anorectal ring, which is formed by the puborectalis muscle, which hooks around the rectum. And from there, you can always clinically feel it by a hooking maneuver when you're doing a digital rectal exam. And then the dentate line can always be visualized, which is the continuous line formed by the anal valves. And behind the anal valves, we have the anal crypts into which the anal glands come and drain into. We know the anal glands are about 6 to 12, depending on each patient, and they are more in the posterior aspect. And we have the columns of Margagni, between which we have the anal crypts. So, sorry. Okay. Now, there are 3 zones which are said in the anal canal, which is the upper zone between the anorectal ring and the dentate line. The mucosa here is columnar mucosa, and then you have the intermediate zone, which is between the dentate line and the white line of Hilton, which is in other words the intersphincteric groove. And then you have the lower zone, which is about 0.8 centimeters between the white line of Hilton and the anal verge. So when you take the upper zone, the other important thing to remember there is the anal transition zone. The upper zone is about 2 to 2.5 centimeters, but just above the dentate line. For about 0.5 to 1 centimeter, you have the anal transition zone, which is very nerve sensitive and which is very important for the sampling of the rectum to find out if it is gas or liquid or solid stool. If you do a stapler hemorrhoidectomy or you do a procedure where you come down like an ultra-low AR or a colorectal anal anastomosis, when you disturb the anal transition zone, that's where you disturb the sampling mechanism of the rectum, and then you end up with a lot of syndromes like the LAR syndromes. So the neurovascular supply, as we are all aware, the watershed area is the dentate line, which is otherwise called as the pectinate line. Above that is going to go into the portal system, and below that is going to come into the systemic circulation. So we know that this is important when it comes to the neurovascular supply. Now coming to the sphincters per se, which is very important for us. We have the internal sphincter, which is continuation of the circular muscle of the rectum. So it's about 3 mm thick, and then it stops short of the external sphincter. It stops about 6 millimeters above the external sphincter. So that's why you have an intersphincter groove corresponding to the Hilton's white line, which is slightly above the anal verge. And then you have what we are not aware as a practicing surgeon, which is the conjoint longitudinal muscle. So you have the circular muscle of the rectum, and then you also have the longitudinal muscle of the rectum. When the longitudinal muscle of the rectum comes down, it continues as the conjoint longitudinal muscle. So this conjoint longitudinal muscle is fairly thick structure, at least in the textbooks, about 2.5 millimeters thick. And this conjoint longitudinal muscle is important for anchoring the anal mucosa. So it gives what is called as, in the next slide I'll show you, it gives the treats muscle which comes across the internal sphincter and then anchors the submucosa and the mucosa, and it also comes down and gives the corrugatus cutis muscle. Then we have the external sphincter, which is into 3 parts, as the subcutaneous part and the superficial part and the deep part, which continues with the levator ani. Okay. So these are a few variations between the internal anal sphincter and the external anal sphincter. The external anal sphincter is about 6 millimeters thick, but the internal anal sphincter is about 3 millimeters thick. And the nerve supply, we should be aware that S2, S3, S4 pudendal nerve supplies the external anal sphincter, and the internal anal sphincter is supplied by the S4 pelvic flank nerves. Now, the other things in the overview which I should touch upon will be your anogenital or the pelvic floor muscles. There is a concept of 3-level arrangement, the fascia and the spaces. So when you come to the pelvic floor muscles per se, this is not the anal muscles. There is a concept of 3 levels of anogenital striated muscles which support the pelvic floor. So you have the levator, which is forming the upper level, and then you have the middle level, which has the superficial external sphincter and the perineal membrane, along with your perineal body, which is formed by the superficial transverse perineal muscle, and then the lower level is the bulbocavernous and the subcutaneous external sphincter. So, I'm sorry. So this is the upper level of the pelvic floor support, which is formed by the levator, and then this is the middle level formed by the perineal membrane, transverse perineal muscle of the perineal body, and the superficial sphincter, which continues as the anococcygeal ligament. And then finally, you have the bulbocavernous muscle and the subcutaneous external sphincter as the third level. This is more important when you think about the pelvic floor prolapse and the pelvic floor support. Now, we all wonder, can we see exactly if you have the superficial, subcutaneous, and the deep part of the external sphincter? These are the cadaveric dissections where you can clearly see that you have the parts of superficial, deep, and the subcutaneous external sphincter. So this is the levator, which is continuing as the deep part. This is the superficial external sphincter, and then finally the subcutaneous external sphincter. And coming to the anogenital fascias, which are important in the abscesses. So we were always thinking that the ischiorectal fossa is one space with an ischiorectal abscess, but it is also divided into infralevator space and ischioanal fossa by the ischioanal fascia. So you have a ischioanal fascia which divides that into upper and middle part, and then between the ischiorectal space and the perianal region, you have the transversalis fascia, which is also called as the Milligan's septum. And of course, in the intersphincter space, there is an intersphincteric fascia. So these are again cadaveric dissections showing the ischioanal fascia. This is a patient who is lying prone with the coccyx, which is seen in the anterior aspect, and you can appreciate there is a clear-cut ischioanal fossa. Many times we put a finger and then try to break the loculi. This is what you're also breaking along with the blood vessels, which ends up in bleeding. So then I'm coming to the last part of it, which is the ischioanal spaces. Now, the importance of knowing this is to know the patterns where we will have the abscesses which can form and which can spread. So you have this cadaver specimen showing us the transverse septum, which is between the infralevator space and the ischioanal space, and also the here you can see in the dissected specimen the ischioanal fascia and also the transverse septum fascia, which is demarcating between the various spaces there. So the spaces here will be supralevator space, which is the uppermost extension of your intersphincteric space, and then you have the infralevator space, and between the levator ani and the uppermost septum there, which is the ischioanal fascia, and then you have the ischioanal space between the fascia there and your lower fascia, which is the transverse fascia, and then you have the perineal space, the perineum space, and intersphincteric space. The other space which are not very familiar and which we fail to open, especially in the posterior deep abscesses or the horseshoe abscesses, is the deep postanal space, which is more predominant posteriorly, and it lies between the external sphincter complexes, and unless you open that space, you will not end up clearing the sepsis completely there. So this is to show the various abscesses in a schematic diagram. So you have all these possibilities because of the anatomy and the fascia there. So in conclusion, we need to have a clear concepts about the sphincter and the pelvic floor anatomy so that we can address the fistula properly and avoid incontinence. We should always remember that there is a variation or there is a variable thickness and length in the male and the female patients when it comes to the muscles and the sphincter complex. And also there is a variation in the same male patient and female patient in anterior and posterior locations. So you should be conscious of the fact when you're doing procedures which cut the sphincter. Fascia and spaces must be understood well so that we understand the spread of the anal sepsis and we tackle it from the source till the end. Thank you.